Welcome to today's IAC webinar, Unlocking the Power of Venous Ultrasound and Intervention in Deep Vein Thrombosis. My name is Laura Humphreys, and I am the Director of Accreditation for Vascular Interventional at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we monitor questions throughout the presentation and will try to answer as many as possible during the Q&A period. Also, on the left sidebar is the Resources tab. Click this tab for a link to today's handout, a PDF copy of the PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those of you who like to take notes during the presentation, look to your right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the SVU CME credit, you must be registered, logged into the webinar, then complete the survey. The link to the survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. If you're viewing this webinar in a group, please be sure you are individually registered and logged into this webinar or on another computer or device so we have record of your attendance. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. And now I'd like to introduce today's guest presenter, Dr. Alexander Misono. Dr. Misono specializes in vascular and interventional radiology and currently serves as Chief of Interventional Radiology for Hoag Irvine, as well as the Medical Director of Vascular Ultrasound and Director of Marketing and Business Development with Newport Harbor Radiology Associates. He's an active researcher in the fields of radiology and interventional radiology, having presented or published more than 50 scientific presentations, abstracts, book chapters, and peer-reviewed publications. With that being said, I will now turn this webinar over to today's speaker, Dr. Alexander Misono. Dr. Misono?
Thank you. Thank you, Laura, for that gracious introduction. And thank you, everybody, for making time out of your busy day to spend a little bit of time with me and the team here. I'm very excited to talk about a topic that is near and dear to my heart, and I think probably to most of you on this call, which is why you're here. Before I even get started on my presentation, I first wanted to just say thank you. Thank you to everybody for the hard work that you do on a daily basis to help patients with all sorts of conditions, and specifically, of course, deep venous thrombosis as well. Your patients thank you. I thank you. And we're grateful for all the work that you do. So let's get started. We have a little bit of time left here, so let's get going. All right, these are my disclosures. So my agenda for today, we'll talk about some things about what patients go through. We'll talk about technology, which I think all of you will be interested in seeing, I hope, and then go into some venous ultrasound thoughts from the perspective of an interventionalist and finish with some case review. All right, so deep venous thrombosis. When I was preparing this presentation, I wanted to see, what does the world think of DVT when they look it up? How does the medical world see this? As we all know, deep venous thrombosis is a blood clotting disorder involving an important vein of the extremity. Typically, what we worry about is going to be the legs, but it can also be in the calf, it could be in the arms, a variety of different places. But what struck me when I was looking at this was a couple of things. Let's not forget that the second sentence of this definition says DVT is the primary cause of pulmonary embolism. So as a provider that's scanning patients and as a provider that's treating patients with this condition, that specter of pulmonary embolism is always on my mind, because patients who might progress to that condition can have significant detriment to their health. But the other thing that really made me curious when I looked at this and what inspires me to give talks like this is that there is a line in there that says, towards the end, treatment is with anticoagulants. And that's all that it says. There is no comment. as to other types of treatment that might exist. And I'd like to ask everybody on the call right now, what other treatments do you know of besides anticoagulation for your patients with deep venous thrombosis? And so I leave a question mark there. And I say, I think this statement is somewhat antiquated. And the reason for presentations like this and my inspiration to bring attention to this disease state, as well as a technology that I'm blessed to be able to bring to patients at their bedside, is that with your help, I think we can change the patient journey and the experience. You have seen pictures like this. These are pictures of some patients that I have treated. And the pictures really do tell, maybe not the whole story as I claim on the title of this slide, but a lot of the story. It is no way to live to have significant limb swelling. It is painful. It can affect even the basic functions of daily living. I have patients who can barely walk because they had a DVT before, never got it treated, and are still suffering from it. In the worst cases, of course, these can progress to limb threat, where there is poor perfusion of the leg. And while we often think of our arterial ischemia as a cause of limb threat, venous pathology, in fact, can drive towards that as well. Going back to the real basic science that many of us learned when we were, frankly, in college, if you took a biology class or a medical class of some sort, we do know that there are risk factors to forming deep venous thrombosis. Some of us are going to have some of these, some of us are going to have more of these, and certainly individuals that have 1, 2, 3 of these risk factors are going to be at more risk of having a deep venous thrombosis. If you scan in the hospital setting or inpatient setting, you may find this commonly, that patients are hypercoagulable because maybe they have a blood factor that makes them more coagulable. Maybe it's simply age, like I wrote here. Certainly cancer and obesity are very common diagnoses that we see in that setting. And then in post-operative patients, they are actually hypercoagulable as well because of inflammation that they have from surgery. But in addition to that, they're lying around in bed, so they have static blood. And then finally, anything we do within the blood vessels, a line or an access or a procedure, can also increase the chance of having a deep venous thrombosis. But this is not to say it's only in patients and hospital patients that can have this. Of course, many of these are present in our outpatients as well. So every single one of you scanning these patients has diagnosed deep venous thrombosis at some point in your career, maybe even today or yesterday you diagnosed somebody with that. But again, I think it's interesting to think about how many patients have those risk factors and who might present to you with those findings. So let's go back a bit to that definition and dig in. Why do we treat? Well, one of the reasons I treat these patients, and we'll talk about technology in a little bit, but one of the reasons I treat these patients is because of concern for propagation and ultimately dislodging and forming a pulmonary embolism, for example. For us as sonographers and those working in the veins, we don't always think about pulmonary embolism as a significant disease state because we're not often called to intervene or scan on those patients when we're focused on the leg. But patients who do develop a pulmonary embolism, this can actually be a fatal condition. This is a condition linked to that DVT you may have just scanned, but believe it or not, a fatal condition. For the all-comers, the patients who have kind of we call it intermediate risk pulmonary embolism is kind of the category in which we get excited as interventionalists, because I happen to also treat PE. The mortality rate in that patient population, believe it or not, is between 6 and 15% at 30 days. That is nothing to sneeze at. And so we take DVT very seriously. The other reason that we are interested in treating DVT is that, well, some of these patients, well, if they have a mild DVT, not a significant set of symptoms, perhaps they can be treated in the outpatient setting. But many of these patients do end up having prolonged hospitalizations because of their deep vein thrombosis. If you've never had a DVT, you may never know, and hopefully you don't yourself ever have to have one. But the pain, the swelling, the decreased mobility that our patients go through can land them in the hospital for days, even a week, I have been to countries where they tell me patients are in the hospital for weeks, that is multiple weeks, with DVT because their symptoms are not improving. They need pain control, they need further tests, and everybody's trying to consult to try to figure out how to help that patient. Why treat in the medium to long term? Well, it turns out that blood clot is not so nice to have, not just acutely, but it can evolve into something much more persistent, into a chronic disease in a large fraction of our patients. So when we look at the epidemiological studies of patients with deep venous thrombosis, it turns out that up to 50% of our patients with deep venous thrombosis develop some form of post-thrombotic syndrome. And what is post-thrombotic syndrome? This is basically the clinical syndrome related to having chronic findings in the veins, chronic venous insufficiency, and or chronic venous fibrosis. And a significant proportion of those have enough symptoms, like some of these patients on the left of the screen. There are pictures of patients with chronic leg swelling, discoloration, even ulcer formation, and healed ulcer formation. And yes, you might look at this and say, oh, maybe this is just simply cosmetic. But it truly is not. These patients with these cosmetic defects that you can visualize, which are helpful for us as providers to assess severity of disease and correlate with deep venous pathology, it is not simply cosmetic because the vast majority of the time it is coupled with other issues such as debilitating limb pain, cramping with ambulation that never gets better, itching that drives them crazy, and even non-healing venous ulcers. Imagine if you had an ulcer on your leg that, first off, people struggle to diagnose and characterize, because we do with this condition. And second, it never gets better, and you find yourself in wound care 1, 2, 3 times a week. This is a condition that takes people out of society. I found it sadly fascinating to look at the quality of life of our patients with, for example, severe post-thrombotic syndrome. So these are patients with multiple of those factors we talked about for venous stasis ulcer. And these patients, when we look at the quality of life, whether they're physical or mental quality of life on validated scoring mechanisms, do very poorly. In fact, they are in line, if not worse, than our patients with COPD, cancer, CHF, conditions that we historically have looked at as being extraordinarily debilitating, either physically or mentally. So this is a serious thing. And if we have the ability to diagnose efficiently, not miss patients that need potential intervention or at least consultation with an interventionalist, and then ultimately get them to potentially procedures to help them rapidly, we may be able to avoid that in a large proportion of our patients. So that's my introduction really to this, to ground us all on the importance of this condition and make us appreciate that it's not just a patient coming in for a scan. It's not just a patient walking into clinic. This is a patient who has a whole life outside of this office, outside of your office. They have a whole life out there, and we want them to be able to live that life. So what do? How can I actually address this? It turns out, well, first, let's talk about who we're actually treating with intervention. So I have a number of technology at play, which even 5 years ago, if we rewind the clock, I didn't really have a lot of these technologies. And I'll have a slide in a bit where I mention a couple of the technologies that we have on the shelf in a lot of the hospitals and labs across the country to treat patients like this. But you got to know who we're treating. I think that's really important. Currently, as I say here, the real targets of treatment are predominantly patients with iliocable DVT and iliofemoral DVT. If there is one thing you take away from this meeting today, that might be it. That's why it's in big red and bold, and then it's underlined. Easy to remember. Why do I care about iliocable and iliofemoral DVT? Think about it for a second. It's pretty, hopefully, clear, and it is easy to remember. Those are big veins. So they contain the most clot, and therefore that's where we focus the most. As of yet, the smaller veins, such as the femoral and popliteal and even tibial veins, are treated by us, but remain in some cases controversial. And the techniques that we have are not as slam dunk amazing as we have in iliofemoral and iliocable. Not to say we do not treat, but those are often require a bit more conversation. Note that I am focused a lot on the legs today because I think that's where the epidemiology drives us. That's where most of our patients are, and that's where we see some of the most debilitating conditions related to DVT. However, we can treat in other locations as well, whether it's the SVC, the upper extremity veins, even visceral veins. The other reason why we treat, by the way, gets back to you should be wondering by now. Well, he keeps talking about post-thrombotic syndrome and why it's so bad, and these patients have really bad clinical outcomes, and their quality of life is just as bad as a patient with end-stage cancer and CHF. Why, though, right? Why is that the case? And the reason is basically, there's a lot of words on here. There's a graph on the bottom left that probably looks like rocket science at this point, but I'll try to talk you through it, right? Which is that PTS develops because of persistent thrombus. So this is clot that has remained within the vessels despite therapy, optimal therapy, which, as we saw on the first slide, is really regarded to be anticoagulation by a lot of individuals. After anticoagulation, thrombus that is left over, unfortunately, acts a bit like glue and a bit like plaster at the same time. Thrombus turns into more of a fibrotic, scar-like material relatively rapidly. And so if we look at the pictures in the bottom left of the slide, this actually is a study in a mouse model that looked at the change in the composition of thrombus from acute, which is brand new within days, to a week and even weeks. And what we found by looking in animal models and watching how thrombus would evolve is that thrombus changes very rapidly from a very kind of almost liquid, gelatinous kind of substance, which will be amenable to anticoagulation. But it turns from that into more scar-like tissue extraordinarily rapidly. And as that scar tissue forms, the valves stop working, the veins stop working, the venous pressure head starts to rise, and it can be difficult to treat with medical management. The truth is now, with technology, I can kind of treat all forms of thrombus, but I'd rather get to it earlier if I can. So there are actually multiple ways to treat. Again, is it just anticoagulation? I think that's just one of multiple different techniques with which we can treat our patients with deep venous thrombosis. I still remember the day when the DOACs came to market, and it was a phenomenal day for physicians and care providers everywhere because we were so happy that we could get patients on a reliable form of anticoagulation without having to send them to clinics to measure their levels and titrate their dose and so forth of old-fashioned medications. So that day has come and has been with us for a while, but there are still other techniques that we should not forget. Rarely performed, although still indicated, right, is things like surgical embolectomy, where a surgeon may cut down to the vein and sweep the clot out with a balloon. Because of the advent of some of the other techniques that I'm mentioning in a second, that has actually fallen a bit out of favor. These days, the things that people tend to do, not just in this country, but kind of all over the world. I'm sitting in the USA right now, if there's any international people, but everywhere across the world, it's basically coming down to either catheter-directed thrombolysis, which is a technique where we put a catheter into the vein and then drip thrombolytics for a period of sometimes hours to days, or sometimes I've heard weeks of this kind of therapy that people might do on and off to treat our patients. That, at least in my practice, has also fallen out of favor, though, because it requires patients to go to the ICU and carries a significant risk of hemorrhage. So now that I've mentioned all of those, let me convince you that catheter thrombectomy should change everything, should change the game. I believe it is here to stay, And then ultimately, I think it should change the way we scan our patients. So the modern era is truly amazing. I am not even doing justice to the complexity and excitement of this market. That is to say, if again, we rewound the clock 5 years, this little chart that I made of different size companies and different types of technologies would basically be blank. And so now I've listed some of the players, not even all of the players in the market these days. There is an incredible amount of energy and innovation and excitement as it relates to deep venous thrombosis. Believe it or not, there's a lot of excitement in this space. And those of you who've been scanning for a long time are maybe puzzled. Why are people so excited about it? And I think it is because many of these technologies work. They are changing the game for patients. Now, I put in red here, and this is a really interesting point, I think, at least for me, I believe strongly in this, that the presence of rapid innovation, I believe, is fueling, depending on the place you go, a disconnect between providers and those of us who do interventionalists or do interventions and are interventionalists. And that's because the providers, how would they possibly know that a patient with DVT, when they're taking care of 100 different medical conditions, how would they possibly know that for DVT, oh, there's these new techniques, right? Unless they have a friend who's an interventionalist or just treated a patient who somehow got an intervention, how would they know? And that's something I've seen kind of repeated throughout the market. And so rapid innovation sometimes requires others to help catch up. Who can help catch up? I believe very much that sonography can be some of the glue that brings people together, because sonographers interface with both the interventionalists as well as those providers who are at the bedside or in the clinic seeing these patients. So I will not bore you with all the ins and outs of all these different catheters. There's a lot of different cool looking, exciting looking catheters on the market, all shapes, colors, sizes, catheters with things inside of them, things that spin, catheters that kind of remove clot off the walls in an atraumatic fashion. So we have really, what a great time to live, that doctors are able to access all these types of things, all these technologies to suit your patient's needs. So in summary, we have a lot of novel technologies available, novel techniques. And I really do want to mention techniques, is that the presence of technology, our access to technology, and our facility with it has not only advanced the actual engineering of what's on our tables and what we're putting inside the vessels of our patients, but actually has made us better operators as well. And so previously, let's say, untreatable DVTs are now treatable. The number of times I have treated patients who come to me in my clinic and say, "Doc, every doctor I've seen so far said there is nothing they could do." But when I dig into it a little bit, I realize it's not that the doctor was wrong. No, there probably was nothing they could do 3 years ago, 4 years ago, 5 years ago when they saw my patient. And it is only now, with the advent of novel techniques and technology, that I happen to be in a place where I could treat that particular patient. So, brave new world, and patients have the potential to tremendously benefit from our work, but only if they are identified and diagnosed properly. So is there such a thing as a perfect venous ultrasound? Venous sonography is perhaps, in many cases, the first line and the last line of defense in the chain of command of DVT care. I don't mean to scare you by saying that. It should be an honor to be in that position, and I view it with utmost respect. We have frontline providers, in the clinic, maybe in the ER, wherever, that need to order the studies. Are pretty good about that. They need to call the interventionalist should something come up. They're pretty good about that as well. Depends on the setting. There's the imagers who need to read the images properly and make the appropriate recommendation and so forth. And, they're pretty good at that as well. Then there's the interventionalists, and we're all very, all over the place sometimes with the technology we choose, but we do tend to take an interest in the disease process and we do tend to intervene. Now, at any given institution, some of the stakeholders throughout this value chain, if you will, maybe are not quite as invested. And certainly, by the way, I'm always happy to talk about this more if your institution is interested in digging into one or the other. And those of you on the call, my email address is on the last slide and the first slide, so you're always welcome to email me to talk about that. But I will focus on sonographers here and say, whether you're in the vascular lab, whether you're in the radiology lab, I work in both settings personally, your ability to diagnose and characterize disease and your approach to communicating that with the interpreting physician, whether it be a radiologist or vascular lab reader, your role there is potentially very big. And if you have questions, for instance, diagnostic clues, maybe don't miss that question by moving on, but instead raise it as a possible issue. If there is something important, always document, report out, and communicate, as opposed to maybe bury it somewhere in the body of your preliminary report. These are things that you can do, and probably there's a list of a dozen other things you can do to surface this diagnosis and surface these issues to the imagers to finalize any recommendations or reports. And that's why I think, really, sonographers, it's not just that it's a big yellow box there, are truly the first and the last line of defense in a lot of our patients. So I said before, if there's one thing you're going to remember, it's which veins I'm interested in, and basically that's going to be, this is going to be the second thing to remember, really kind of very, very basic tenets to how I look at anatomy and venous physiology. I'm an interventionalist. I know some people call me a fancy plumber. I think very simply when it comes to this, right? One, bigger veins are more important. It sounds almost silly that I say that, but I got to tell you, people think very algorithmically. They think by checklists. They think by templates. And people are going through systematically, almost like robots, and saying, okay, clot, no clot, clot, no clot, and not really thinking to themselves, what is the impact of that on my patient? I see this all the time. Remember that not only do I care more about the bigger veins, such as the IVC and iliac veins, so iliocaval, iliofemoral veins, but trust me, your patient does too. They're probably not going to talk about it with that anatomy and those terminologies, but they care because their symptoms are potentially significant. Two, and this too is really important. It's the first time I'm talking about this today. We said if you find DVT, you need to find out, or at least try to find out, how high up, how high up does the clot go? So what does that really mean? This means that the patient has clot in the leg, and they have clot up to the common femoral vein, and maybe you're able to scan to the level of the iliac vein, and there's clot in every window that you have. What do you do right now? Do you simply report that out and leave it for, let's say, the interpreting physician to decide what to do with? Okay, is that what you do? Or, as time and resources allow, would you say, hey, I'm concerned as to how high up the clot goes? Is it possible, if a patient has common femoral and iliac vein thrombus, that they actually have common iliac thrombus or even IVC thrombus? Is that possible? The answer is of course, yes, it is possible. And so instead of simply checking off boxes that we checked those veins for thrombus and they were there or they were not there, I would like us to be thinking physiologically about that question of what's actually going on inside of this patient and have the curiosity to ask that question and potentially go and look at it, right? You may need to get an order or whatever the protocols would be to actually go and look at the iliac veins in the IVC, which is in fact quite possible to do in many patients. And then to look at the contralateral vein and study those waveforms to see if there's a waveform abnormality that might clue you into a true central thrombosis, perhaps in the IVC. So think anatomically and think physiologically, where could this DVT extend to? How high up does it go? Remembering that Dr. Misono said that the bigger the clot, the more concerned I am. And that leads me, of course, to number three, which is that sometimes you will have cases where you can't even find the DVT. The patient's symptomatic and you are scratching your head because there's no DVT. Doesn't mean there isn't a DVT, it just means you haven't seen it. And so if there are, for example, abnormal waveforms, do not overlook those. If there are symptoms that are incongruent with the findings that you have, look more carefully. If there is right lower extremity thrombus and you don't know how high up that clot goes, look more carefully at the waveforms in the left leg, even if that leg is free of DVT. So always look for that hidden DVT. So if you follow these 3 points and kind of internalize them, and if you have any questions about them, reach out to me and I'm happy to talk over it with you. But if you follow these 3 tenets, if you will, I think we are much more likely to capture all these patients. And so to put it graphically, inside my head, this is how I think. Again, I told you, interventionalists, we're plumbers, fairly simple in terms of the way that I approach problems. I like the big veins. This is like the third time I've said it because it is so important. IVC iliac veins, very important. FemPop, still fairly important. And then, of course, the calf veins, still important, but in terms of an intervention, a little bit less so. So in the last 15 minutes or so before we go to Q&A, remember you can definitely, whatever you want to ask, please feel free to put that in the box and we'll try to get back to you. I would like to cover just 1 or 2 cases and show you what it actually looks like. So this is a case study of a patient of mine with who is 35, had a pelvic sarcoma, and had actually undergone an operative resection. And you can read the bottom box, but what I really like is for you to look at the images and think for a second, what's going on here? And I think this is a pretty interesting type of scan. So obviously this is just 2 pictures from thousands of pictures that would have obtained during that scan. But I believe there is a filling defect in the right common femoral vein, and the femoral vein below it has completely flattened waveforms. Now, do you typically study the femoral vein for waveforms? Usually I'm looking at the common femoral vein, but I think it's interesting here to bring back that idea of physiology and say, well, why are there flattened waveforms here? They probably should still be somewhat phasic, even though it is the femoral vein. And the flattened waveforms here, of course, are due to the more central obstruction, which at this point actually is the common femoral vein. Here's a CT scan. And so I generally do really like to get CT scans when I'm working up my patients with this type of history and condition and new diagnosis. And so again, this is a right lower extremity swelling in a right common femoral vein DVT that we have documented. And this CT scan shows actually a very large hematoma in the pelvis. It almost looks like the bladder, but it's actually hematoma. The bladder is being compressed out of the way. And where the red arrow is pointing is really where the femoral vein, or the common femoral to external iliac vein transition would be, and really where the external iliac vein should be living. You can't see it at all. And so that vein is essentially completely either compressed or simply not visible, and there is no blood that is clearly flowing through there. So actually, before I get to the next slide, I'll add also that I learned after talking to the surgeon, this was a resection case, that there was some bleeding out of that external iliac vein during the procedure. And they ended up having to kind of sew that area shut. And so there was probably a combination of a bit of a laceration there, and then an iatrogenic almost closure of that vein. So I am now dealing with something that, should give all of us a little bit of heartburn. I'm having acute DVT. I have a potentially sewn shut, iatrogenically closed external iliac vein and a significant hematoma. But we can solve these now. And so you might think, I hope you're thinking, wow, how do you solve a problem like that? It turns out it's relatively rapidly. I can solve it. And so on the left, you see an angiogram here. I put the patient on their belly and I access from behind the knee because I need to clear out the groin area. And so I can't go in the groin like I might typically do for another procedure. This venogram shows where the red arrow is a very, very large filling defect, which is the thrombus we just saw with sonography. And then along where the blue arrows are pointing is where there should be a normal external iliac vein, but of course it is missing. On screen right, this is actually one of the technologies that I have. This is an aspiration-based technology where I use a very large syringe device in order to generate negative pressure, and as if I'm drinking like a Coke really rapidly, basically generating lots of negative pressure and sucking the thrombus out. And the red arrow is kind of pointing to the technology there. So after literally maybe a couple of minutes, I was able to remove these kinds of chunks of thrombotic material out of the vein. And then in the middle of the slide, you are now seeing that after thrombectomy, all of the thrombus that we previously saw is gone. However, the iliac venous obstruction persists, right? So there is no contrast flow cranially or upwards in a fashion that would mimic that of the normal iliac artery. So in order to solve that, I was able to get across, and then here I am placing a stent. And so we do have novel dedicated venous stent technology for this kind of disease state. That is also relatively new, only a couple of years we've had these stents on the market in the US. But with that technology, I was able to achieve this. And so this is after thrombectomy, venous recanalization, and then venous stenting. And take a look at that venogram. Beautiful venogram. Looks almost normal. You almost can't even see the stent unless you squint. And no more DVT. So, in conclusion on this case, there's a lot of technology that we have to bring to bear for our patients with this condition. And why is it so important that we identify them? Because gentlemen like this that had severe right lower extremity swelling. By the way, it was debilitating swelling. So much so that you would touch the leg and he would scream. At 4 months follow-up, his hematoma is not quite gone yet, as you see there, but his veins are widely patent and he's back to normal function. You might be wondering, well, you did a great intervention. What do you do in follow-up? So I do scan these patients in follow-up. The anatomy that I scan depends a bit on the intervention that I did. It's very customized as to what I did. Is it thrombectomy? Is there a stent? Where is the stent? And so forth. I do follow a typical kind of normal timing for these. I follow them up usually at about a month, 3 months, 6 months, and then a year. And so it gives a bit of more intensive looks at the beginning. And then after a year, depends on the patient, I may continue to scan. If they have hardware implantation, such as a stent, I'm kind of scanning yearly after that. Our patient, by the way, remains asymptomatic to this day. So in the last bit here, I will go through one more case study and say, well, I'll leave this with not everything is so simple. So not every case is straightforward. This is a 50-year-old gentleman with abdominal pain. He's had occasional chest pain too, maybe some mild mild lower extremity swelling. It's been on for days, weeks. He's not really sure. He has an IVC filter. It's been in there for a while. He's not even sure when that was placed, but never had it addressed, and he's not on blood thinners. So you hear this kind of history and you go, ooh, right? Every single person on this call is like, oh, I don't know what's going on with this guy. On examination, he's got some edema in the lower extremities. So I'll have you take a look at this. I'm going to show you the right lower extremity venous ultrasound, which shows no DVT in terms of compressibility of that vein, that's for sure. I'm going to take a look at these waveforms here. And then I'm going to go to the left in a second. So that's the right common femoral vein waveforms. And go to the left. These are left common femoral vein waveforms. And again, we're doing some compression here, common femoral vein disappears. So I'm not seeing an active DVT kind of anywhere. And then again, comparison right versus left leg. I am curious of your thoughts here, and there is some augmentation maneuver that is done here, actually on both sides. So now that you've had a chance to look at it, I'll give you kind of my thoughts on it, which is that there is no DVT that I can see. However, may I convince you that there is something here that's a little bit different. I think there's a little bit of a decreased phasicity in the right common femoral vein, not maybe in isolation, but particularly when compared to the left common femoral vein. There's also lack of augmentation in the right common femoral vein. It's not marked, but we didn't see it. And the left as well. maybe also some decreased waveforms in the left common femoral vein. Now, I may not convince you that those findings are individually true because it is so subtle, but do you agree with me that there is in fact a subtle asymmetry? And I think, and I go back and kind of drive right back through, but isn't there a subtle asymmetry in the sides here, right versus left? So even something of this form, right? You don't have to just have flat waveforms to say, oh my gosh, there's something going on, right? If you see flattened waveforms, well, you better say there's something going on. I don't think that should be buried in a preliminary report or not mentioned. I think that should be surfaced to the imaging physician to finalize the report and say there are flat waveforms, this is abnormal. We need to come up with a differential diagnosis for what that is. But in this case, it's simply a subtle asymmetry. For me, that subtle asymmetry, albeit uncommon, I believe should query or raise a query for central pathology. So CT abdomen and pelvis with a venographic phase is kind of my favorite tool to look for this kind of thing. And if you take a look here, very interestingly, there is a initially partially occlusive kind of towards the top. And as we come down, more occlusive thrombosis involving the IVC filter. And so ultimately, albeit very, very subtle in terms of finding, there is extensive thrombosis that is above the filter and also involving the filter and involving at that point the IVC. It's a very, very interesting type of presentation for this. I've also outlined, by the way, in blue, the location of the renal veins just for your own edification. And of course, the IVC filter is here in orange. Because of the DVT, we also did a CT pulmonary angiogram that shows a small pulmonary embolism. Patient also had some pulmonary symptoms, but luckily for him, the pulmonary embolism was relatively small. So imagine if this ultrasound was interpreted as completely normal. It's kind of scary to think. And I don't want to scare you with this case because this is kind of very, very rare, but it's trying to drive home the point that we really, really should be taking every bit of data that we have and using it to our advantage. If we had missed the fact that there was subtle difference in the waveforms and at least asked, right? Ask, why is it a little bit different? Doesn't look quite right. Then this patient may have been discharged without any further workup. Their IVC thrombus could have been missed. Their diagnosis of PE may have also been missed. There is floating thrombus above that IVC filter, kind of attached to it, probably swaying in the wind. If that were to fall, that could be a potentially life-altering or even life-ending pulmonary embolism. And of course, no anticoagulation would have begun because the diagnosis would have been entirely missed. So again, sonography may be the first and the last line of defense for our patients. So let me walk you through what I did find. And so if you take a look at the screen middle, the red arrows are outlining the location of that big thrombus sitting in the IVC. And in fact, on the video, on the screen, on far screen left, you can see the thrombus swaying in the wind, if you will. There is flow past it, but the flow is not nearly as rapid as it typically is in a venocavogram. To make a long story short, the next thing that I did was work very, very hard to mobilize the thrombus from above the filter and remove it from the body. So here I am taking an aspiration catheter again. You can see it's sort of the ghost of it in the bottom left of the picture. You see the IVC filter labeled here. And then all these rounded white areas that look like you chewed gum and spit it out and put it on the screen. That stuff is the DVT. And so I was able already to move that DVT from above the filter to below the filter. And then ultimately with some additional steps I will spare you because it's just additional work and plumbing, I removed this material from this patient. This material scares me. It scares me because it could have easily been missed on sonogram. It scares me because anticoagulation, which the patient would not have even begun because they would have not been caught. But even anticoagulation would not manage a patient like this because this material is basically fibrous rubbery scar. And it scares me because fibrous rubbery scar, when it embolizes to the lungs, has a really bad effect because it can really plug up the vessels. There is no pliability, and the body's metabolism of this material is poor. And so their risk of having significant acute PE problems as well as chronic PE problems rises quite a bit. But again, sparing you of all the details of all the work that I did, after intervention, Now you can see how fast the IVC actually flows and washes out. The thrombus burden has been nearly completely cleared after aspiration thrombectomy. And then I also checked the lungs to make sure they were clear, despite me having worked very extensively around this cable thrombus. In the pulmonary bed is actually very, looks pretty good. And you can't even see that small thrombus that we saw on the CT scan, although it is still there. For completeness sake, I will share with you also that because I had cleared all the thrombus, I actually decided preoperatively that if I was able to clear the thrombus, I would take the IVC filter out. And so I did remove it. And then the final venogram on the right shows the true completion, which is essentially normal. This is what, if I did a venogram on you who's watching this right now, that's what your venogram should look like. Very rapid washout with no thrombus inside. So this patient did very well. They went to the floor. They didn't go to the ICU, even though they had a big DVT. They went home post-op day 1 and returned with no symptoms. And we did get a post-operative CT scan to ensure that everything looks good as it does on the angiogram, and indeed it does. So there is no DVT left over on either the axial or the coronal reformats. And there is obviously the IVC filter is gone as well. It looks like there's good contrast flow throughout. We also took a look at the pulmonary embolism, again, to kind of prove to ourselves, particularly because of the chronicity of that thrombus material, that the lungs remain clear. We didn't throw anything up there, nothing embolized up there as well. So it brings me to my conclusions here. And again, thank you. Thank you for taking the time. Thank you for everything that you do. Thank you for scanning your patients with care. Thank you for taking an interest in this. A DVT is a very significant condition, potentially very severe disease. Novel technologies can really change the way that your patients will respond to this disease, can change your patients' lives and maybe even save their lives. I think the identification and diagnosis is really one of the most important steps in sonography. Is not just the first, but also the last line of defense for many of our patients. And I will ask you after today to remember those key points that we talked about. The big veins are the most important. Think both anatomically and physiologically. Ask yourself, how far up does this thrombus go? And always look for that hidden thrombus. And I will leave it at that. Thank you very much for your time and attention. And again, feel free to reach out anytime, and let's take some questions.
All right. At this time, we'll begin the Q&A session. Laura, would you like to get us started?
Sure. Thanks, Marge, and thank you, Dr. Misono, for a lot of great material. And we do have quite a few questions here, as you can imagine. The first is, how many centimeters from the common femoral and gastrocnemius would you consider a thrombus a DVT?
That's an interesting question. I mean, so for me, I think anatomically, so if it's involving a true deep vein, from an interventional perspective, I would consider any kind of named deep vessel to be a DVT. Now, gastrocnemius vein and other veins like muscular veins are kind of borderline for me in terms of the way that I think about it. So I think there is the diagnostic side of things where you have to follow the rule book as to what's a DVT and what's not a DVT. But from an interventional perspective, I think much more kind of mechanistically as to what's a significant DVT, what's a DVT that's going to cause a lot of potentially debilitating or maybe even irreversible thrombotic burden for the patient. So I'm not sure if that exactly answers the question, but I don't have a centimeter marking so much. I'm thinking very mechanistically and physiologically as it relates to my patients.
Great. We have a question about treatment of calf vein DVT. Mm-hmm. Do you recommend treating them aggressively with blood thinners?
Yeah, so this is a topic of great. I bet we could do a whole hour on that. And so I think calf vein DVT should be one that is, well, first off, I do not think we have very good or comprehensive guidelines as it relates to calf vein DVT management. So that is the truth, right? That is still where we are. we've gotten so much better, especially you all on the call, right? The sonography's gotten so much better in the ability to identify and characterize caffeine DVT. I remember training in an era where we had a lot of trouble even seeing, and I think part of it is just technique, part of it's technology, the crystals are better, whatever, right? That it's a better way to look. But that leaves us in like a bit of a quandary where we are now able to diagnose a lot of caffeine DVT, and it's a question. There is a question as to the clinical importance of that, and even for the first question, I answered with that, right? Clinical. What is the clinical manifestation of that for that patient, and what are the clinical implications for basically the safety or the danger of having that thrombus in that patient? And so, one patient who has, let's say, very poor cardiac reserve and they have an acute DVT and a tibial clot, or let's say a gastroc vein or wherever, right? Somewhere where there's a little bit more controversy of what to do with that thrombotic burden. That might be a patient, let's say poor cardiac reserve, really concerned about propagation, bedridden, that you might be thinking about anticoagulation or maybe an IVC filter. Another patient who's young and healthy and got the DVT because of whatever reason, but they're active and they're able to get around, they can put their compression stockings on. That might be somebody we watch. We would do serial ultrasounds and ensure there is no propagation. And when we do that, by the way, a lot of those patients never propagate. So it does require some more time and effort than just putting something on AC and forgetting about it. But that may be the right thing for that patient. So we're still figuring that out, I think, as a community of treaters. And when I say I'm less interested in tibial vein DVT for intervention, I don't mean to say I'm not interested at all, by the way, too. So some patients have DVT throughout their leg and it's extending into the tibial veins, and they need work done on their tibial veins too. And some of those devices go into the tibial veins. They're small enough to get in there. They're small enough to make a difference. So there may even be intervention for some of your patients with tibial vein thrombus.
Great, thank you. I have a question on the ultrasound side. Is there ever a setting where it's safe or acceptable to do augmentation when a patient has an acute or chronic DVT?
Yeah. So in acute DVT, I think augmentation, we're all a bit, we all are a bit wary of that because acute DVT, I'll tell you, I have seen DVT move when I am in the veins. Like I literally have watched a DVT that was here move there because it was so acute that it was slipping and sliding around. And so, yes, people get concerned about augmentation or even compression, but in this era where we're able to, so if it's truly acute, okay, that might be a setting where I would be wary of that. But we are in an era where we can much better tell the difference between acute versus chronic DVT. And then particularly when, let's say, there is no DVT that you can see and you're trying to figure out what's happening, that may be a setting to use augmentation. And then in chronic DVT, I basically have almost no concern about an augmentation maneuver, other than that the patient will probably find it uncomfortable because of their chronic venous fibrosis issue, that even compression may be untenable for that patient. But they can serve a very significant value potentially for your patients. Now, ultimately, this is not something we would solve and decide on a call like this. I mean, I think this is somewhat of a team-based, institution-based question as to what your protocol and approach might be for problem-solving cases like that. In particular, where I am, if there was a case like that, they might call me and they'd say, "Hey, what do you want me to do?" And we could come up with a bit of a game plan for how to assess that patient, because ultimately this is a very dynamic exam, and sometimes that one extra maneuver or trick may answer your question.
Great. There's a lot around the caffeine. So one more question about ultrasound. Do you think that the sonographer should routinely evaluate the caffeines?
That's a great question. I believe so. I think that even though I said there's the less clear treatment paradigm for that, we do have some clarity, but it's not like there's no checklist you can go down and say, okay, this because of this, it's this. I think it's a bit of a custom job with the caffeine. I think it's important to look at the caffeines because first off, if you do it, you get better at it. It's not the easiest veins to look at. I know that because I do interventions down there, and it's not that easy, right, compared to a common femoral or femoral vein. And so even if you scan and it's negative, every time you do it, you're getting better. And so when there is a patient that actually does have a caffeine pathology, Or maybe it's not even isolated. Maybe it's caffeine pathology plus other stuff going on. You know who's interested in that? I'm actually interested in that. Maybe less interested, but I'm still very interested. For me to know that there is a caffeine DVT and a FEMPOP DVT versus a FEMPOP DVT and the caffeines are open makes a big difference for the way I approach that patient. And so if you're able to give me that intelligence on that patient reliably every time, that means something. But the only way I think to do that in a very, very good and reproducible fashion is to scan every time.
Great. We have a question about the procedures.
Mhm.
Do thrombectomies cause vessel trauma, and could that cause risk for recurrent DVT in patients with disorders like factor V?
Yeah, that's a fantastic question and a topic that we all think about in intervention. So, can intervention cause vascular trauma? The truth is, any intervention that you do can cause vascular trauma if you try. If you let's say have a complication, have an issue, you're in the wrong channel because we struggle a lot sometimes with getting into the correct place. Of course, that's my problem, not your problem, but getting into the correct place in the vessel in order to deliver my technology and the effect of that technology. But by and large, the interesting thing these days is that the technology we have, and again, I listed half a dozen different pieces of technology. A lot of them are generated and designed specifically that we might be able to use them in the veins, inside the vascular structures. And so the engineers who've designed these have specifically said, how do we make sure that they are safe to put in there and that they are not going to cause damage to the vessels under routine use, which is going to be the vast majority of cases. So whereas you can always find a story of someone who had a struggle, generally speaking, my principle is this, and I don't think this was not on my slides, but another point to remember, the general principle is that your devices carry some risk, of course. But if you leave thrombus in the vein, as we talked about, the thrombus can age and it can become that chronic problem and chronic issue for that patient, maybe even chronically debilitating. Leaving the thrombus in there, in my opinion, is a higher risk than trying to take it out with any of these kind of validated technologies.
Okay, segue into a question about chronic clot.
Mm-hmm.
What are the chances of a chronic clot, say over a year, breaking off and causing a PE?
Yeah, well, that's a difficult question. So well, I will still, kind of answer it in generalities and probabilistically. So, I mean, anything could fly, right? For example, that case I showed with that IVC thrombus that was clearly very chronic, but it was moving. That clot was probably been there for a long time, and yet it was technically mobile. So, yes, there are instances that are very rare where I suppose a clot might move, but that's probably, I don't know, 1 in 10,000, 1 in 100,000 type of case, a case example. If we go back to that one slide and that teaching point about how the clot changes and evolves rapidly over time, what we have seen is that as clot changes from more of that hyperacute, hypoechoic, almost mobile feeling defect within the vein into more of that chronic looking, hyperechoic, like fibrinous appearance, often with scarring and shrinking of the vein, that as it makes that transition, it turns into much more stuck. It turns into much more of a permanent type of object within that vein. In fact, I have to do everything I can to the point where my biceps hurt sometimes after these procedures to try and remove some of that clot. So just to give you an idea, most of that chronic thrombus ain't going anywhere, no matter what you do, because I can't even get it out until I really work hard.
Wow, great. Thank you. I think that that's all the time we have for now. I do appreciate your time.
Thank you for the questions.
Sure.
All right. Thanks again, everyone. And a very special thank you to Dr. Misono for this presentation today. Feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credits for attending this webinar, please complete the survey. The link to the survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. On the left side of my account page, you'll click on Webinars. Look for the title of this session, Unlocking the Power of Venous Ultrasound and Intervention in Deep Venous Thrombosis. Beneath this title, you will click Review Event. Then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen and anytime thereafter through the CE transcript section on the My Account page. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.